All right. All right. Good morning, everyone. Uh, Thank you all for coming to Grand Rounds this morning. We have a great talk planned. It is my very good pleasure to introduce Dr. Karen Brasel this morning, albeit I'm probably a little underqualified to introduce such a big name in the world of general surgery. Um, Dr. Brasel comes to us from OHSU in Portland, Oregon, where she serves as a trauma and acute care surgeon, uh, and also the residency program director for one of the biggest residencies in the country. We were talking last night, they have 13 categorical residents, 17 prelim residents, is that right? Across 11 hospitals in the state of Oregon. Dr. Brasel has Midwestern ties with her training, graduating from the University of Iowa Medical School, and then went on to the University of Minnesota for residency, where she developed a love for Big Ten football, specifically the Iowa Hawkeyes. But as a Nebraska fan, I won't hold that against her. From there, she went on to the University of North Carolina for her surgical critical care fellowship. In regards to her academic career, she is a giant in the world of surgery with nearly 400 peer-reviewed publications. Her work has been cited over 14,000 times, and she serves on numerous committees throughout the world of surgery, including the Western Trauma Association, the AAST, ACGME, and the American Board of Surgery. Very recently, this is hot off the press, she was named a 2023 ACGME given the Courage to Teach Award for her innovation in resident education and her work as a program director in Oregon. She's here today to discuss her work, part of her work on the American Board of Surgery, not representing the American Board of Surgery, but the future of resident education and entrustable professional activities. So we all look forward to hearing what she has to say and learning what the future holds starting in July of 2023. So without further ado, Dr. Brasel, thanks for being here.
Thanks very much, Chad. And that's actually probably the best introduction anybody's ever given me. If you can work in Iowa Hawkeye football to an introduction, that's definitely my speed. It's really a pleasure to be here, and it is amazing for somebody who's never been to Temple and whose Texas geography is horrible. We established that yesterday. I have so many connections to people here, starting in the non-medical arena. My little sister went to college with Papa, and if you want some stories, she's shared a few that I'll be happy to share later. Up to and including, and if I started to name them all, we would be here for quite a while, but I very much appreciate y'all sharing Chad with us for a year. He is truly a pleasure, and it's great to get to see him again. I am here to talk about entrustable professional activities. I have no financial disclosures, but as you can maybe guess from the slide, I'm a convert. So many of you may be skeptics about a new way of educating, and that's fine. For those who have a little gray hair in the audience, thinking, you know, the system that produced me had to have been a good system because it produced me. And why would we want to change that? I'll ask you to think about what you do in the operating room. And I can guarantee that, looks like in this group, faculty sit more on the left, that those on the left side, what you do in the operating room is not the same thing and not the same way that you did it when you were trained. It wasn't the robot for many of you here. For some of us, laparoscopy was just getting started. And so why should we think that the way we educate should be exactly the same that it was in Halstead's era? And the answer is it shouldn't. There are new and better ways to teach, particularly because what y'all have to learn is a whole lot more than what we had to learn. There's more knowledge. The doubling time for medical knowledge is now about 70 days. And there are more techniques. So we should be better and more efficient at how we teach. So my objectives are to tell you what an EPA is if you don't know what they are, to describe the benefit and probably the most important objectives to all of you, not just for the people over here, is to commit to using entrustment language at least once in the next week and at least half a dozen times in the next month. So EPAs are entrustable professional activities. They are a tool for competency-based education, or CBME. And I will tell you that the next iteration of the program requirements for general surgery, so that's the language that the ACGME uses and that all residency programs must enact. The next set of program requirements, which are probably going to be in effect in 2025, if not 2024, are going to require that all assessments, all evaluations, be done using a competency-based framework. They're not going to require EPAs, but EPAs are going to be probably the easiest way to do that. They're units of professional practice, so things that practicing general surgeons do that may be entrusted to a learner to execute unsupervised. And here's where we all start to get really nervous. We're gonna let a whole bunch of people go out and do unsupervised. No, that is not what entrustable professional activities are. It's an assessment that says I could let them be unsupervised, but says nothing about letting them be unsupervised. And that is the first hurdle to get over when thinking about entrustable professional activities. Nobody is talking about letting residents run amok, even though they're probably more competent to do that than you might think, but nobody is talking about letting residents run amok. It is stepping back and saying, I know I really didn't need to be here. I inserted myself in a lot of different places, but I really probably didn't need to be here. And it enables a shift from the individual competencies, which I hope most of you could get at least 3 or 4 of them: medical knowledge, patient care, communication, professionalism, systems-based practice, practice-based learning. Now you are asked to evaluate residents on each of those individual competencies, rather than stepping back and saying, I think this resident can take care of patients with right lower quadrant pain, and demonstrate all of those individual competencies in the care of a patient or patients with right lower quadrant pain, right upper quadrant pain, small bowel obstruction, needing dialysis access. They all roll up into the care of a patient. And we don't look at a trainee, be it a student or resident, say they're demonstrating good medical knowledge. That's not really how we think as faculty. We think they're taking good care of my patient with appendicitis, or they know how to care for a patient with biliary tract disease. We don't think in that sort of individual assessment, and that's EPAs are aligned or meant to align with the way we take care of patients. So a little bit more on EPAs. They are a work-based assessment. As I said, they're a holistic assessment, not the individual competencies. They are When they are best used, they are learner-driven and directly observable. I cannot assess a resident using an EPA or a competency-based framework unless I'm there to observe. So the fact that somebody said that this resident can or can't do X, Y, Z, can't use that. You have to be there to directly observe behaviors. And at their best, they are frequent and formative. We'll talk about how they can be used as summative assessment and provide data that are super helpful for both residents and faculty, particularly program directors and clinical competency committees. But they are supposed to be frequent and formative. I'll give you an example. Two examples actually from our experience using EPAs in the pilot. One was a chief resident who was running a trauma. We got the trauma page, came across highest level of activation, hypotensive. I don't remember the mechanism. So we get to the trauma bay, the resident gets the team set up, does a pre-brief, patient comes in, we resuscitate the patient, probably was blunt since we treat mostly blunt trauma, so we probably went to the CT scanner and the details are a little fuzzy. And then I fill out an EPA. And I say to the resident, you did a good job. You got the team together. Your plan was great. You looked at the CT scan as it was scrolling through, made the diagnosis, got the patient in ICU bed, and you're entrusted under direct observation. And he sort of looked at me like, well, you just told me I did a good job. I said, you did a good job with all of those things, and you didn't order blood, which now we do automatically for our full traumas. But that's part of I had to order the blood, make sure the blood was ordered. Doesn't take away the fact that there was a great resident, great resuscitation, did a good job. Nothing to do with my overall assessment of the resident. And he's like, oh yeah, I didn't even think about it. Never made that mistake again. And that was one assessment. The rest of his assessments were clustered at indirect supervision or practice ready. And so it did not affect, it was not like giving him a black mark. It gave him some information on how to improve. So they are formative. I had another resident who, a senior resident, when I first got to OHSU, and I got a call from one of the site directors at one of our community hospitals. He says, this resident can't operate. I said, well, that's a problem. That's what we're here. He's senior. What do you mean the resident can't operate? And he said, can't operate. So I brought the resident in and we talked a little bit and said, can you tell me why I might be getting this feedback? And by that time, we'd done a little bit of education about EPAs. He said, yeah, I can't do anything in the operating room under any degree of entrustability beyond direct supervision. I said, well, this is giving me a powerful lesson on EPAs. I said, okay, tell me how we're going to fix that. He said, I don't want to fix it. I don't want to be a surgeon. And he is now a phenomenal critical care practitioner through a different pathway. But it enables a conversation to happen that without that language, he had been struggling for actually quite some time. So you have to be there. You have to have direct observation in order to make entrustment decisions. And it turns out that in the operating room is the best place that we have to do this. And it also turns out that much of the preoperative work that is done, seeing consults, seeing patients in the emergency department, and much of the postoperative care, we are already entrusting, and we have been entrusting residents to provide that care for a very long time without, without that direct observation. And so we have a unique opportunity in the operating room to provide a lot of that direct observation and to provide the entrustment, feedback, if you will. So that's what EPAs are. Why have we decided as an educational community that we need to make this jump or make this move? And I think this really is the crux. It turns the equation for learning into a part. And I can tell you, I was not trained to be a partner in my learning as a surgical resident. That was not you went and you did, and if you heard nothing, that was great. You were allowed to keep going. And if you started to hear things about your performance, that meant you were in trouble. And first of all, that's not the best way to educate. And it leaves a lot of room for improvement. And it's not how residents come to us anymore, if they ever did. That's not how people are educated in college. That's not how people are educated in medical school anymore. They are expecting a partnership and expecting to be able to drive some of the learning. And that's one of the reasons there can be a disconnect when they get to graduate medical education. So it really places the emphasis on the residents to seek out the educational opportunity and to seek out the feedback. It asks us as faculty to think about the trust aspect or the trust equation. Would we trust this resident to do this case, take care of this patient, evaluate this patient in clinic, evaluate this patient without us there? Again, we're going to be there. We've already moved that to the side. We're going to be there, but have they demonstrated all of the competencies rolled up into one so that we can trust them? We can trust them without us being there. We can trust them to call us if they have a question, and we can have taken one step back or two steps back, or do we trust that we're going to have to be there to move their hand back, to point things out on the screen, to make sure that this question gets asked in clinic, to make sure that this gets done in a trauma resuscitation? It's about trust, which is the holistic aspect of education that we've been doing for forever, and it makes that explicit. One of the reasons it enables that dialogue is that every aspect of that underlies or underpins that trust is specified, and it's specified through behaviors. We'll get into that a little bit more, those clear anchors, so that the resident knows why they were assessed as needing direct observation. When I told the resident he was, I was giving him an evaluation or an assessment that said direct observation, he knew exactly the reason why. There's no argument, no, oh, now you think I'm a bad resident. Oh, yeah, I didn't do that. I'll do it next time. Let's move on. Makes it very unemotional, clear, and explicit. It also helps address some of the issues of faculty burnout. the pediatrics has piloted Entrustable professional activities. And one of the things that they noted was that it gives more focus and brings back some of the joy in teaching. Because the learner comes and says, I know what I need to do. I'm looking to engage with you in that. And rather than coming and not having focus to the educational encounter. EPAs also address the psychology of assessment. And anytime you have a power dynamic and an environment or a place where somebody's going to be assessed, the person being assessed wants to be told that they're doing a good job. You cannot change that, especially if the evaluation is seen as summative. And as evaluators, most of the time, we want to tell people they're doing a good job. And so if somebody's working hard and communicating well and putting in the effort, we are likely to tell them they're doing a good job. And the problem with that is that you get a senior resident that can't operate. And I'm not suggesting that is happening here at all. But it doesn't address, we are not giving feedback on the things that we need to give feedback on. And so EPAs start to move this conversation and move this psychology so that rather than thinking about, well, this resident wants to do a good job and they're a pleasant person, thinking about the outcome. Is the behavior they're demonstrating going to be safe with the patients they're taking care of? And so in this transition period, as the faculty start to think that, the residents are still going to want to be assessed as being entrustable at the highest level. And what hopefully we can move to is getting to everybody is thinking about wanting to be practice ready. And it is not about being practice ready right off the bat. It is about learning the specific behaviors that you need to demonstrate to get to practice ready that don't have anything to do with whether the faculty like you, think you're a good resident. It is about demonstrating behaviors. And the way we get there is by having a shared mental model. And that's where the defined behaviors come in. So every entrustable professional activity has a set of defined behaviors that you know as residents, that you know as faculty, and it is a simple matter of saying, did this resident demonstrate these behaviors in this clinical situation? And it should take about 60 to 90 seconds, or in my case, how long it takes me to walk from the trauma bay to the CT scanner to fill out an EPA. And so there's really no excuse why I don't do that for every single trauma patient I see. I will tell you I don't. I try to do it at least once a night when I'm on call, but there's really it takes about 90 seconds. Dr. Provost will still have time to clean the OR and make the bed and still complete an EPA. It also, as residents, it allows you to know what you need to do to move to the next level. The behaviors are all written out. So you know exactly what you need to do. And then when you have gathered enough assessments that say, I'm entrustable at indirect supervision, Dr. Hall is still treating you like you're at direct supervision, you can come to him and say, you need to let me do more and you need to stay away. And so it's the data and the concept are really powerful from the learner perspective. From the faculty perspective, Well, it's from the learner's perspective. We have to sort of the second, if the first hurdle is the unsupervised and understanding we're not talking about that. The second hurdle is really truly understanding that these are formative. And everybody in the program, from the chair to the program director to the clinical competency committee, understands that these are formative. And I've stolen this from Rebecca Minter, but EPAs are really like a GPS. So they show you how to get where you want to go. You want to be practice ready, and you want to get to practice ready as soon as you can, so that the faculty will sit in the corner of the operating room, and they won't question your decisions, or if they do, they're really trying to get you to think much more deeply. The EPAs are a roadmap. So how have we done this, and how are we continuing to move with this? The Board of Surgery started with a pilot study, and the purpose of the pilot study was really to get some information on feasibility. Sure, this is a great idea, and pediatrics had done a little bit. Actually comes from the Netherlands. The concept was developed in the Netherlands. But could surgeons and surgical residency programs actually do this? And so we got 28 sites and designed this over 2 years. And we collected the number of assessments, whether there was summative entrustment, how much confidence we were able to have in the levels of entrustment, and then some data on milestones. And these are the 28 programs. We tried to be representative from a geographic standpoint, tried to be representative from a resource standpoint. Some programs had a lot of resources they were able to use to roll this out, and some had very little resources, and a representative sample of community-based programs and programs that are based more in an academic center. These were the 5 EPAs that we initially used. And when we started to talk about which EPAs we were going to use, the project almost was dead in the water at that point because, well, colorectal is most important. Well, surgical oncology is most important. Well, trauma is most important. Well, I don't know that anybody was advocating for transplant. Sorry, Deb. But and so we actually looked at case logs for general surgeons, those who had been who were recertifying from the American Board of Surgery standpoint, and tried to take the 3 most common conditions and operations. And so that's how we ended up with hernia, appendectomy or right lower quadrant pain, and cholecystectomy. And we also wanted to see if we could assess things like communication and leadership, because that is so important to surgical training and so important to general surgeons. And that's how we ended up with consult and trauma evaluation. And you can see there's a lot of logos here. The board really served as a convener, and the people who wrote these EPAs and implemented these EPAs went well beyond the board. We had fellows and residents that were part of developing the pilot as well. And these are the levels of entrustment: limited participation, direct supervision, meaning I needed to be here this time, and if the same thing happened tomorrow, same patient, even if some magic wand that is not going to happen in the way healthcare is practiced in the United States came down, I would still have to be here. Indirect supervision, same case, same set of circumstances, magic wand. I need to be around so that I could come running quite quickly if you needed me, but I don't have to be there. I wouldn't have to be there the entire time. Practice ready, I wouldn't need to be there. And can teach others. Not only would I not need to be there, you're actually demonstrating enough that you would be able to take somebody else through this case or this evaluation or this postoperative care. Again, we've already discussed, you're going to be there anyway. So now let's run through some of the specific behaviors. And we're going to take one phase of care, so the preoperative phase of care, and we're going to take one EPA, inguinal hernia. So these are specific behaviors that would lead to an assessment of limited participation. And hopefully you can all understand why these behaviors would lead to an assessment of limited participation. These behaviors would lead to an assessment of direct supervision. And there are similar analogous behaviors for the operative phase and the postoperative phase. Behaviors that are associated with indirect supervision, again, preoperative inguinal hernia. Practice ready or oversight. And then can supervise other residents. Although I can tell you that this fifth level, if you will, is definitely not the focus of the initial EPA rollout. So now let's move to present day. The board, after looking at the pilot, decided to adopt Entrustable professional activities and require them for the interns that will be starting this July. So those of you who are chiefs are going, I'm done, don't have to deal with this at all. And added 13 additional EPAs. So 13 add 5, get 18, covers 85% of what a general surgeon in practice would do. Not meant to try to define absolutely everything, but to define the most common things. In addition to working on creating these EPAs, and they're almost done, there's a group that's working on faculty development resources and resident development resources. And there's a technology group that is working on the app that will be rolled out free to all programs. And when I say the EPAs are almost done, this is what happens for every single EPA. And these are those behaviors. So every EPA has the 5 levels of entrustment and has a preoperative or pre-resuscitation aspect, a procedural or intraoperative, and then a post-operative or post-resuscitation. And there are a couple of the EPAs. The trauma one, you may not go to the operating room. The patient that's critically ill, you may not go to the operating room, but you will have procedures. Patient with a small bowel obstruction, that intraoperative one may be blank because you don't operate on all patients with a bowel obstruction. And then this is what the app could look like. You figure out which resident, you create a new assessment, and it should have the ability to dictate into the behaviors that should be displayed in order for the resident to proceed to the next level of entrustment. So what did we learn from the pilot? So we have 2 years of data. Unfortunately, uh, not as much data as we had hoped because of COVID. And that's not only because case numbers went down some, it's because the bandwidth of programs to be able to have their support staff and the educational administration to enter data went down, just like everybody's bandwidth went down in COVID. But what we've learned is that the intraoperative aspect of deploying EPAs is pretty easy. Pre and post-operative care, we entrust a lot of that without the direct observation. It is possible. There were programs in the pilot that had an inordinate number of assessments. So it is possible with the right tools, the right buy-in, and the right support to make this work. Without the right tools, without buy-in, and without support, it doesn't work very well. And if you give this to frontline faculty as something extra to do without taking something away, it's not going to work. It is a paradigm shift, and training and more familiarity with several aspects of EPAs are really key to making it work. Several of the places in the pilot used non-surgical assessors, particularly for consult and trauma. And several sites were able to make that work pretty well. The resident buy-in was very good. And as I said, many residents have already been entrusted, particularly for non-operative aspects of care. So this is the timeline. We conducted the pilot, we did the pilot, we planned the launch, we're going to do the launch, and then in 2028, seems a long time away, we'll get the first cohort. It's going to be 10 years before we know the impact of what we're doing right now. And I hope that as a surgical community, we have the patience to wait that long, because that is not our nature. We did not go into surgery to start something that's going to take 10 years to figure out. That's why people went into medicine. So, July of 2023. Now that, on the other hand, that is coming up very, very quickly. So what can all of us do to get ready for July of 2023? We don't even have the app yet. As I said, the EPAs aren't even finalized yet. So what can we do right now? Well, I've talked about EPAs being kind of this broad. It's the care of a patient with right lower quadrant pain. It is the care of a patient with a bowel obstruction. It is the evaluation of a patient who needs dialysis access. Are you actually going to do a fistula, or maybe they want peritoneal dialysis, or maybe they actually should be referred for transplant? So it's not the little pieces. It's this whole thing. But what you can do between now and July of 2023, and if you go back to my objectives, you can do it once this week and a few times this month. You can start using the same language for smaller aspects of patient care. For port placement, for doing a coloanal anastomosis, for presenting a patient in clinic, for fascial closure. I would entrust you to close fascia under indirect supervision. I would entrust you to place ports for a bariatric operation under practice-ready conditions. You can start using the language and you can start asking for the language before you know anything about what the exact specific behaviors are going to be with each individual EPA. Based on what I observed today, in this clinical context, I would entrust you to provide this level of care tomorrow under indirect supervision. That's the language. Yes, it will be anchored to specific behaviors, but you can start practicing now. Okay, this has all been great. What is in it for me? What's in it for me as a resident? What's in it for me as a faculty member? What's in it for me as a program director? What's in it for us as a clinical competency committee? Because if we can't answer this question, probably not going to work very well. So what's in it for residents is holding faculty to what you're being evaluated on. How many times have you gotten an evaluation back? I checked, Deb's not going to hold this against you. How many times have you gotten an evaluation back and gone, what on earth did they see in me that caused them to say this? Now you know. And you can use those data to help drive your own learning, to say, this is what I want to work on, and I want to get to the level of indirect supervision. You need to tell me which one of these behaviors so that I can get to direct supervision. What's in it for faculty? There's that joy piece. So, and I'm not afraid to talk about some of the squishy things that make our job fun. But there's also data. So these are the data, they're made up, but these are the data that will come to the clinical competency, that will come to the program director from the formative evaluations. So if you, these are 3 made up residents. And if you look over to the left, those formative data cluster around indirect supervision. So that the CCC could make a summative entrustment decision that that resident was entrustable for whatever EPA this was, say inguinal hernia, was entrustable under indirect supervision. And then could then feed that forward for the next rotation. So that rather than having to sort of come and prove yourself, and I've not operated with this faculty in a while, you come in and they know what you're supposed to be able to do. Take the resident in the middle, there's a little bit wider spread. So there was one clinical context that was observation only. There was one clinical context that said unsupervised, which is what we used to call practice ready. Caused a lot of consternation, so we changed the language. And most of this then will probably cluster direct supervision. And then on the right, this is my resident who I had the assessment of direct supervision for not getting blood to a trauma resuscitation. But you can see most of the evaluations cluster at practice ready or unsupervised. So that the one direct supervision doesn't affect the overall summative assessment. This also points out it is really important to get a lot of these evaluations. Because if we only had for the resident to the right, one direct supervision, one indirect supervision, and one practice ready, we wouldn't know what to do as a CCC. So it's really important for from the summative aspect to make the work of the CCC a whole lot easier than it is now, to have a lot of these formative assessments. It also, if you do enough of these, your end of rotation evaluations probably won't go away, but can become a whole lot simpler. Maybe 3 questions on an end of rotation evaluation to get at things that the EPAs don't actually assess. So the time that hopefully everybody spends on evaluating residents doing their end of rotation evaluations, that time shrinks to just a tiny bit. So that's what it can do for the individual faculty and the program. So I like to think EPAs, yes, they're entrustable professional activities, but I like to think of the EPA as expectations. What do I need to do as a resident? What do I need to do? And then I get evaluated on how well I did that specific behavior, not am I a good resident or not. And I also then know what I need to perform to get to the next level of autonomy. Because what we are all about is the gradual release of responsibility. And the EPAs provide a way to use frequent formative feedback based on that shared mental model, the GPS. So in summary, EPAs use entrustment language. We can use that language without actually having the EPAs in our hands. It is a partnership. It's an educational partnership between residents and faculty. There's loads of educational data to show that a partnership model is how adults learn, and that it's better than the way that we were trained. It is a way to improve feedback evaluation, and almost every residency program in the country, residents want more autonomy and more frequent feedback. Second to work hours, feedback and evaluation is the most frequent citation that the surgery RC gives. And EPAs give us, as program leadership, more and better information on resident performance. Thank you all very much for your attention, for the invitation, and I look forward to any and all questions, particularly the hard ones.
That was fantastic.
Oh, here it is.
Awesome. That was great. I mean, and actually for me, you know, sitting on the board and being on the committee, I now understand EPAs better. So thank you so much for coming and giving that to us. I think we can all probably understand what the EPAs are, and I just love the fact that you gave us examples of the language. I would probably venture to say that everybody in here has learned this language before. In my situation, my wife entrusted me to take care of my kid when he was 2 years old and she had to go out of town. And she actually told me that I trust you to take care of your kid. So I think we can probably put it in that context. I did have a couple of questions and I did write them down. So I'm going to look at my phone. So I apologize about that. Should there be an EPA for the educator? In other words, we're doing the EPA's entrustable activities for the residents on the activity that they do, but should they be evaluating us as teachers, and because they're entrusting us to teach them the things just as much as we're entrusting them to take care of patients? It might be a loaded question, but have we thought about that at the board level?
We haven't thought of EPAs for educators that I know of, but we have actually just last year come out with ACGME milestones for educators. So that's, I think, the first step. I do think the EPAs will give program directors a window into how well faculty educate, because if as a program director I have a group of residents, and Dr. Smith has evaluated them as practice ready, most of his cluster at practice ready for a group of 3 residents. And Dr. Hall clusters at practice ready. And you cluster at direct supervision. And I've got several other, Dr. Provost clusters at practice ready, and you cluster at direct supervision. That tells me the problem is likely with you.
Sure.
And
It usually is.
you pick on your friends most, right? And so it gives a window. So that's not specifically an EPA for educators, but it will give the program a
Just looking for an outlier.
yeah, you're looking
Right.
for an outlier. This is all about looking for outliers. And
Yeah.
and we talked last night. There are people that know the statistical language for that. You're just looking for outliers.
Yeah. Anybody have any questions? I'm gonna start here.
Hey, I'm Anthony. I'm one of the interns. So to me, the formation part sounds great. The feedback is what I want as a resident. But my question is, how arduous did the faculty find it? And do you think, would they keep doing it without prompting? Like, did the faculty like it at the site, at the 28 sites that you trialed this at?
So there are things that the faculty like, and there are things that the faculty don't like. The things, if you make it more than probably 3 clicks, you've lost most faculty. And so it needs to be easy. The engagement with learning, that the I'm going to make an assumption that is almost always true. The faculty are here rather than the hospital across town because they want to work with you. And anything that increases that engagement, and being able to have a discussion about specific behaviors rather than them thinking, oh, well, what should I ask them today? I can't remember if I asked them this yesterday. So anything that helps that conversation increases their engagement. And faculty like when it is not 100% their responsibility. So a shared responsibility for feedback actually is faculty are very receptive to that. It works best when it's pushed so that the faculty don't have to remember, oh, I operated with Andrew today. Now I have to go to some website or open an app and remember to do this. It works best when something gets pushed out and they can click and say something opens and do the EPA. It literally takes about 60 seconds. Our CT scanner is less than 100 yards from our trauma resuscitation bay, and I was done by the time. So I opened it as I was leaving the trauma resuscitation bay, and I was done with the EPA by the time I got to the CT scanner if I was just evaluating the resuscitative aspects. So I was serious that Provost would still have enough time to do all that stuff that he does. Fair enough.
A wonderful presentation, very, very provocative stuff. I mean, a lot of these concepts are things that even those of us who were trained back in the age of dinosaurs are familiar with. The idea of having effective feedback from faculty, having faculty trust you with certain activities after determining competence to proceed. And this is a project that has looked at those elements to try to codify them.
Yes.
And collect data.
Yeah.
And to better use a large number of observations to create some data-driven assessment. So I think the idea of this is all very consistent with what we've been doing in surgical education throughout the modern era. What I'm interested in is how the board is going to use the data. You said they're going to look at it in 10 years, but one of the challenges, not just for each program director getting all the faculty to buy in, but all the programs and the variability of the data that are collected. The programs, the educators that provide most of the feedback might be the ones who are most interested and engaged. And there may be a large number of faculty who are less so. And there might be programs that have a higher level of administrative support, financial support, faculty buy-in, and there might be a few that don't have that same level. How is the board going to collect all those data and determine the biases to be able to make a comparison across the nation?
So the board is not going to collect the individual formative assessments. That would, if I were a resident, that would be a non-starter. I don't want the board knowing my direct.
Are we training a better product?
Yeah, I think looking at board pass rates and patient outcomes, I mean, those are the what you have to look at. And then the board will in some form or fashion, and this is a little bit flying the plane while it is being built, be able to look at the number of assessments per faculty per trainee and performance on the boards to see if that is if there is a correlation there. It's a loaded question because how do you prove something is better than the system that has existed for forever? Are there fewer citations on the from the ACGME? I mean, that might be a way to look at things. That certainly would be a success from the program administrative burden, all of that standpoint. So looking at adverse actions, looking at board pass rates, and looking at there will be metrics of engagement to be able to look at, as well as the feedback and evaluation citation, I think would be a reasonable metric to look at.
I have a question that kind of carries on from that a little bit. In 2003, the work hour changes happened, and it wasn't until a decade later that Carl Billamoria ran the first trial that was finally published in 2016. We've got a situation where the public was told, we need to change work hours, it's great. And finally, when the first trial was done, it showed actually there wasn't really a major difference in outcome, and you had degraded some of the components of like engagement between residents and their patients, a team feeling. Like there were a bunch of different things that clearly had actually been degraded, at least in surgical residencies. So my question is kind of, we're going from a pilot to wholesale rollout. Is there a middle ground of begin with an iterative rollout, like half of programs roll this out, half don't, and then you can kind of see if there's an improvement, and if you're seeing metrics, then do a stepwise rollout or some other model? Because we have a lot of things, if you look over the course of education in America, like how many times in the last 50 years have we cycled to pass fail back to grades? And it's like you keep, it's a kind of rolling experiment without clear objective evidence. So if this really works well, like what's the metric? Are we going to see all of our qualifying exams just be a really narrow set? Or are we still going to expect 30% of people to fail the first time they take the test? That's kind of what we expect from the boards right now. That kind of helps demonstrate it actually means something. But if this is really effective and you're actually honing the education better, you should either see a really narrow set or the fail rate drops. I mean, do we have preset objective measures that are going to show this is improving things? We're going to look at like, are people getting fewer state medical board actions? I mean, what are do we have preset metrics to know that we're actually delivering something to the public that is as good as what we think it is? Because my experience starting residency a year after the work hours, I'm a pediatric surgeon, so I was a professional trainee for 9 years. It was constantly rehashing to the residents, oh, you're lazy because you're under this restricted work hour thing. You're not getting enough cases. We're not sure you're going to be ready to graduate because you're not doing what we did back in the day of Q2 call. And then when the first trial actually showed that wasn't really the case. So kind of what are we going to do to prove not only like to the public and to ourselves this is actually effective?
Yeah, so what this is designed to replace is the program director's signature. Because right now, what the public has to know that the people that leave this program are competent is the program director's signature with no underlying objective data at all, except case logs and an evaluation or an evaluation file that is not released. So this will provide, so that's a way to start, is you now have data that that show that you have evaluated and have documented that the residents are practice ready according to these predefined metrics and behaviors. That, independent of, is this a randomized controlled trial set up to look at this new way compared to the old way, that it will be a data-driven decision versus a signature. So there is validity in that, in sort of independent of a research project or what are we going to make better? It is the sort of the data underpinning that signature. Other metrics include the amount of time that it takes to get practice ready. This may very well be what gets us to time variable training and earlier entry into fellowships. Because if we are able to show that residents get to practice ready in 3 years for a defined set of procedures, there is no reason for us to need to hold them 5 years and earlier entry into, but without that, without data to support that, that argument is dead in the water. So it will, because there are a large number of people that do not believe that you need to take 9 years of training to do what you do. But without data, there's no way to move that needle. And so there are, can I say for certain or with confidence that there is going to be an outcome that we're going to be able to show with statistical significance in 10 years? I'm not sure that I'm there. Do I think there are going to be other benefits, such as showing where the length of training, where we can have an earlier off-ramp to do, trauma, to do surgical critical care, to do pediatric surgery, to do whatever it is? I think that that possibility certainly exists. So to me, the having the data to support the practice ready aspects and to be able to define the length of training that's actually necessary to train a general surgeon, and to train a general surgeon that is interested in going into a subspecialty, these are the data that will allow that.
Listen, got another very good coming in, but I just wanted to thank you so much for coming in and being our guest and being our background speaker. It's fantastic. Good to see you, and just throw your shit back behind. If we want to continue the conversation outside, we can. Let's give Dr. Brasel a
Thank you all.